Hi, I'm Siobhan from Angelman Academy, and we're so excited to bring you a very special webinar that we know can really make an impact in supporting individuals with Angelman syndrome. So today we have Dr. Chris Keary. Dr. Keary is the behavioral director at the Massachusetts General Hospital Angelman Syndrome Clinic. He's a child, adolescent, and adult psychiatrist with expertise in clinical care for individuals with developmental disorders. He works with families to develop treatment plans and addressing behavioral and mental health concerns in patients with Angelman syndrome. He conducts research and teaching focusing on improving behavioral health and quality of care for people with developmental disorders. He's really a world-class expert on Angelman syndrome, and we're thrilled to have him here today. So may I present Dr. Chris Keary.
Thank you so much for the introduction. So kind. And for the opportunity to talk with you all today. Thank you for your attention. And thank you to the Angelman Academy as well for hosting. We're gonna talk about behavioral concerns and anxiety concerns in kids, teens, and adults with Angelman syndrome. This is where I see patients here in Lexington, Massachusetts, where part of where we see patients for the Angelman Syndrome Clinic at Mass General. I am gonna focus today on using a couple of cases as a jumping off grounds to talk about what I'd put as some of the more common reasons that a family might be referred to me or see me for a behavioral concern for their loved one with Angelman. I find that information sticks in my head better if I'm working from a case. So we'll use 3 cases as our jumping off grounds for 3 more common concerns. In each of those cases, we'll talk a little bit about what the parents are concerned about, and we'll then talk a little bit about the research behind how big a concern that is in people with Angelman syndrome, what we know from the research. And then I'll comment a little bit on treatment approach, focusing first on behavioral, non-medication based approaches, and then speaking briefly about some medicines that might help with that particular area of concern. So again, thank you for your attention today. I start every lecture with a little comment on disclosures. These are some of my disclosures over the past 5 years. We're giving this presentation in September of 2022. And no treatment that I'm going to talk about today, no medication I'm going to talk about today has any financial connection to any of my disclosures. Similarly, when we talk about medications, a lot of these medicines have not been formally studied in people with Angelman syndrome. So that means they're all off-label, which is to say they've not been specifically studied in populations with Angelman syndrome, but can still be effective. And I'm not selling anything to you today. All right, let's start with the case, John. John's a 19-year-old man. He's got Angelman syndrome via uniparental disomy, UPD. And the parents' main concern is that, particularly after the pandemic, John is increasingly upset, agitated, whenever there's separation from their parent, separation from a loved one. Sometimes the separation doesn't need to be very big, just a parent moving into the other room, or the parent's attention being divided in the same room. Like taking John to a doctor's appointment is very tough, because whenever mom starts talking to the doctor and shifts attention away from John, that can pull for a lot of agitated behaviors. They sometimes can be dangerous, can include aggression, pinching, biting, scratching, kicking, and can also be very disruptive, like throwing items around the room, sometimes hard items that can really hurt people. Sometimes that agitation is more around specific limit setting, like, okay, we're leaving the pool, or we're transitioning to a non-preferred activity like the bedtime routine, or setting a limit around more food. These are circumstances where they're also seeing these behaviors. Increasingly, it's become hard to get John to, the parents to feel comfortable taking John on community outings. It's always been very important to the parents to include John as much as his siblings in the world around him, and having new experiences, seeing new things, going new places, meeting new people. And increasingly that's hard for John. And his life is, for that reason, getting smaller. And that's a real concern of the parents. So this is their main concern that they're coming with today. So let's use this case as a jumping off ground to talk a little bit first about aggression and agitation in people with Angelman syndrome. This particular issue has been studied a lot in people with Angelman. Particularly, let's start with talking about research trials that might tell us about how common it is. So there was a trial that was done in 2011, which compared the frequency of aggressive behaviors in people with Angelman syndrome to other known genetic causes of a developmental disability or developmental delay, and found that the frequency of aggressive behaviors was among the highest among the genetic syndromes that the different genetic syndromes were studied. So this particular study suggested that even among other neurodevelopmental disorders, that is to say, disorders that might cause a developmental delay starting with early development, it was among the highest frequency of having this problem. There was a separate study of Angelman syndrome that was done with a smaller group by Logan Wink's group in 2015 that found high measures on a particular outcome measure that measured the severity of aggressive behaviors or how frequent they were as a problem. So this study, although it was smaller, found that it was a pretty frequent problem. The natural history study has been one of the most important research trials out there that might tell us how prevalent a problem is. This is a very important trial. If you're not aware of it, it's still ongoing now, and if you're not already participating, you should consider it. A lot of the different Angelman syndrome sites collaborate on the natural history study, and this is a study that's very large for a study of Angelman syndrome, 300 subjects for this particular publication. And they recruited from 6 different study sites over 8 years, looking at the prevalence of certain behavioral concerns. And the table you can see in front of you here shows some particular behavioral concerns and how the percentage of people that had it based on their particular mechanism of inheritance for Angelman syndrome, deletion versus uniparental disomy, imprinting disorders versus a specific mutation of UBE3A versus total. And if you jump down to, if you look at the behavior, that's the far column on your left, and you look at aggressive behaviors, you see numbers that are pretty high. You're 50% of patients with deletion, 84% with uniparental disomy, also relatively high 70% with UBE3A, suggesting that this might be somewhat more prevalent in people with Angelman that have those mechanisms of inheritance for their Angelman syndrome. Higher rates of biting, pinching, hair pulling. So this trial really emphasized as well that it seems to be a relatively common problem. This trial also found that for some subgroups within Angelman syndrome, it appeared to maybe be more likely as age went on, particularly individuals that had UBE3A. This might be simply because as people with Angelman get bigger, their bodies are larger, it can become more of a concern when they do pinching, biting. It's a much bigger concern in a 17-year-old than it is in a 7-year-old. So it could reflect the getting larger. Some of those same problems are no longer easily manageable. So how do we understand aggression? When I see a family and this is their chief concern, I'll try to ask some questions that help me understand, if possible, what might be some of the things that drive that particular behavior. So I've listed here on this slide some of the big ones that I've noticed and research has found over time. One of them I've written up here top. We'll just start at the top and move clockwise. Anger. So when I think about leaving the pool, having to do something that you don't want to do, a non-preferred demand where frustration may be going on, this can be part of what's driving aggression. You're asking something non-preferred, the person with Angelman is feeling frustration or anger. Maybe you see that anger on their face and there's a quick move to an aggressive behavior. There's a thin line between this and communication. Because you could see that as communication as well in an individual who doesn't want to, doesn't have a good way to let you know that they don't want something or that they do want something. So aggression can also be one of the few ways that an individual can let them know, I'm not happy with this, I don't want it. Ideally, the goal in speech therapy, augmentative communication strategies in speech therapy is to give people with Angelman other strategies to let them know, I don't want this, I want a break, to request something else, other more healthy ways or safer ways, I guess you could say, to communicate. But sometimes that frustration results in kind of a temper tantrum that could go on for a long period and can result in a lot of unsafe behaviors. And in that situation, I'm thinking about frustration tolerance and anger. Let's move on to attention seeking. This is a really big one in Angelman syndrome in my experience. For many people I work with Angelman, they have a strong love for their people and the people that they know and trust and care about, their family. And there is a strong desire to have those people's attention, physical closeness, eye contact. And when that attention is divided, these behaviors, aggressive, disruptive behaviors, are very effective in pulling the attention of those loved family members, loved caregivers, preferred teachers back to them. It's really hard set of behaviors to ignore: aggression, property damage, self-injury in some cases. It's also important to think about how attention seeking, can sometimes, attention-seeking behaviors can still be present, even if you're giving someone your full attention. And I think about that as being attention maintaining. Okay, I've got your attention, I want to keep it. I'm going to keep doing this behavior because I know it keeps you locked in. It keeps your attention on me. So again, I'm thinking from the communication lens, is there another way that that person with Angelman can use to pull in the attention that's less disruptive, that's more socially appropriate, that's not going to make it so that they can't be around their peers? That might be the usage of a communication device to say, I want a high five, or I want to say hi, or I want to do peekaboo, or patty cake, or some sort of social interaction. If we follow along the clock here, we've got down here what I've written as sort of social excitement, or overexcitement, or social delight. A couple different ways of putting this. For some people I work with Angelman, they can get easily keyed up, overexcited, overstimulated with that social contact that they crave. And in certain, if that social interaction is very vigorous, it can lead to a very overstimulated, silly, disruptive state, which may include aggression in there. I'll give you an example of what I'm talking about. I have a family that I've worked with where their loved one with Angelman syndrome loves hugs. They live for hugs. They're really into it. And when they do a hug, they will quickly move to pull hair or bite or scratch. And it makes hugs really unsafe with this person, especially as they've gotten older. And we've wondered together whether, it could be that that person's trying to keep that physical contact, but they get so giddy in those environments that we've wondered whether or not they're essentially not aware that they are being unsafe with their behavior. They're being unsafe with their body. They're kind of in an overexcited or overstimulated state. Another family I've worked with, when dad will play in a vigorous way, wrestle with the person, his loved one with Angelman and his siblings, he gets into one of these really worked up states. He's laughing and smiling. He's happy, clearly, but he's way overstimulated, disruptive, and it quickly goes over the edge to aggression. Or in situations where you're talking about a very crowded environment where someone is so delighted by all the social contact, and now we've got a lot of dysregulated behavior. So I kind of think about overexcitement, overstimulation as being a trigger as well. And then the last one I'll talk about is pain, which I think is very important for us to not miss and think about in people with Angelman syndrome. On this particular issue of pain, I think in my mind about a couple of conditions that are more common in Angelman syndrome, medical conditions that could result in discomfort or pain that we want to make sure we don't miss. Almost the most important one to think about is constipation. Constipation is more common in Angelman syndrome. It can be a real challenge. It can be exacerbated by very restricted diets or the medications that we give for seizures or behavior. So it can, and then it can be totally unrelated to those things, just an issue that's prevalent in the condition. So constipation is a very important thing to monitor. A lot of families will say that when it's been a couple of days where there's been a bowel movement, they see a lot more of this challenging behavior. So getting on top of routine bowel movements can sometimes reduce some of this challenging behavior. pain, discomfort, or hormonal changes in the 5 to 3 days prior to the onset of menses, or around the days of the onset of menses itself, um, is another common story for a trigger for challenging behavior. Families describing behavior being very difficult to manage, lots of aggression, lots of irritability, and then the patient gets their menses and, oh, okay, we have a break. This is a very common story as well, an important thing to think about in women who have an Angelman syndrome diagnosis. Gastroesophageal reflux is also a little known contributing medical issue. You're looking for actual signs of reflux, dry cough, a sort of signs of regurgitation on the pillow that might suggest that this is taking place. I've seen patients where when gastroesophageal reflux was treated, they saw a definite improvement in challenging behaviors. Dental problems, it's hard for a lot of our loved ones with Angelman syndrome to get regular dental care, sit for a dentist appointment, get their teeth brushed regularly. It's important to think about that as a potential contributing factor. Do people seem like they're having pain when they're eating harder foods or avoiding harder foods because of discomfort? Scoliosis is common in people with Angelman syndrome, common enough that it's important to watch for. It can cause significant back pain. And I've had some patients where when this got addressed with surgery, when it was severe enough, that it helped a lot with behaviors. And then finally, seizures, in the minutes to even some cases hours after a seizure, there can be sort of a confused, tired state that individuals can be in, post-ictal state, post-seizure state. Confusion and sedation in that state can be a common trigger for agitated behavior and is an important thing to rule out and discuss with your neurologist. Okay, so again, how do we think about what the different triggers could be? If we think about that clock of the number of different potential triggers. And the best way to do that is a functional behavioral assessment, FBA, which is a technique that's done by behavioral therapists, people with a BCBA designation, but you don't have to have a BCBA designation to look at this yourself and try to think a little bit about what might be going on. Looking at the antecedent that comes prior to the behavior, that could be my attention is divided from my loved one with Angelman syndrome, and the consequence, the behavior itself, the consequence afterwards. I always bring my attention back to my son when he engages in this behavior. And that can help give you some clues. And understanding that it's very uncommon in Angelman syndrome for it to be just one thing. Oftentimes it's multifactorial: attention seeking, overstimulation, communication, or attention seeking, overstimulation, constipation. It's very common for it to be multifactorial. So it may be different triggers in different situations. So this process of maybe taking a week, 2 weeks, where you look at that behavior, maybe get yourself a little notebook, write down what came before, what happened afterwards, and kind of think through it together as a family of, man, what could be driving this behavior? And that can provide some real clues. Sometimes it's obvious right off the bat. Sometimes it's a little more subtle. When there isn't a clear antecedent and it seems like it comes on out of the blue, watch for whether or not it could be pain related and really discuss it with the medical team taking care of your loved one. And then a hot topic right now in Angelman syndrome is the extent to which anxiety might be a precipitating factor. This is a topic that some increasing research has been devoted towards. In some of the first studies describing individuals with Angelman syndrome, anxiety is mentioned as a concern, a study that was done in 2001, and then some follow-up research in 2015 and 2018, which described parents really concerned about anxiety, behavior that they thought represented anxiety in their loved one with Angelman syndrome. Almost 50% of parents expressed this as a concern in a 2015 study. Persisted into adulthood in a follow-up 2018 trial. There was a trial that my group did that asked parents specifically about if they had a concern about anxiety, what were the behaviors specifically they saw, and what were the circumstances where it occurred. And I'll just pull ahead to that real quick, and then I'll go back to the previous slide. That trial, when we asked parents what was the behaviors they saw that they thought were concerning for anxiety, aggression is number one, with almost 70, a little over 70% of parents who, when they said, yes, I think my loved one with Angelman has anxiety, this is the behavior I see that I think represents it. Loud vocalizations, fearfulness or anxiety, property damage, crying, gagging and vomiting. It represented around 25% of the parents who felt that their loved one had anxiety. And that gagging and vomiting can represent reflux. So you want to make sure you rule that out. In advanced constipation, sometimes you can see that as a concern. So you don't want to miss that, or a medicine side effect. But ruling out those kind of concerns, gagging and vomiting you can see as something that might respond to a treatment that was helpful for anxiety. So it's important to think about that could possibly be related to this. Self-injury, flopping to the ground, agitation, stiffening, sweating, seeking physical reassurance, tremor, hyperactivity. These are the most common behaviors that parents saw they were worried represented anxiety. And the most common circumstances when they saw it, number one was separation, with over 50% of parents describing that. Another common situation was crowds, new places where individuals haven't been to before, a change in routine, unfamiliar people. And then some things that we might think about as almost maybe being phobias: animals, insects, medical appointments, people coming into their personal space, particularly people that may not be preferred caregivers, loud noises, and then transitions and uncertainty. That makes sense if you think about it. If you're not entirely sure what's going to happen next, that can be an anxiety-provoking situation, especially if you're in a new environment. So a lot of parents said that I think they're more anxious when they don't know what's going to happen or what the plan is. There was an important trial that was done in 2019 that by researcher Ann Wheeler's group. She created a particular outcome measure, a tool that where she created a bunch of different question items in her team on common potential triggers for anxiety, and then gave it to a large number of patients with Angelman syndrome, 100. And some of the most common behaviors that were found in their trial were clinginess, not being able to relax, nervous habits, trembling. You could think about maybe trembling and vomiting as being potentially the fight or flight response. And if you think about what happens when you're in a panicked, anxiety-ridden state, maybe there's feelings of nausea, like butterflies in your stomach, a feeling like you're going to pass out, sweating, all these things that our nervous system can do when we have an excess of stress hormones. Trembling as well, something you can see. So these were common items that were identified by family members, and the most common trigger for it was separation. So again, this also replicates that same finding, that it appears that a lot of these behaviors that parents are describing as anxiety occur commonly in situations of separation. There was a trial of a medication that just treats anxiety called Buspirone, and this is kind of additional evidence. We might suggest that anxiety may be a part of it, because this particular medicine that's primarily treats anxiety helped these 3 subjects in this case series. It reduced the frequency of self-injury and aggression. Individuals who were a little more calm, less sweating, were able to go into crowds without as much of this agitated behavior. And a couple of subjects had reduced vomiting behaviors, suggesting that anxiety may be sometimes driving those. So again, it's more evidence that anxiety is likely in the picture. And while we can't know that for sure, because our loved ones with Angelman syndrome can't tell us in their own words, there are a number of features here that are suggestive that anxiety can be in the mix in here. So let's talk a little bit about treatment approach, specifically for these issue of aggressive behaviors, self-injurious behaviors, this kind of disruptive issues that might have a number of different causes for it. Anxiety might be one of them. So let's talk about some non-medication based treatment approaches first, which should always be the first step to take before thinking about medications. I think about occupational therapy oftentimes having a lot to offer patients with Angelman syndrome, kids, teens, and adults, because particularly when the trigger is that overstimulated, overexcited state, because a lot of the interventions that occupational therapists can think about can focus on calming sensory interventions, whether that's things like scented, a weighted blanket, for instance, a hand fidget that individuals can use, other interventions that are similarly along this lines, maybe not as much what OT do, but calming scents that may help sort of bring down a little bit of the oversensory stimulation. So OTs can think about these higher sensory states and some techniques that may bring it down some, using that concept of zones of regulation. Speech therapy and AAC approaches are kind of like the long game to think about with these challenging behaviors, because so often attention-seeking communication is what drives a lot of these challenging behaviors. So we want to give people with Angelman syndrome other tools to use to be able to express their wants, their needs, whether that's for social contact, whether that's for affection, whether that's to say, I don't want to do this anymore. If an individual has those techniques, then that's going to help reduce a lot of these challenging behaviors. That's not an overnight thing, that's a long-term thing, but can be very helpful. Having a way to request breaks or preferred items, using visual schedules with icons to have a sense of what's going to happen next, having a visual icon that can be given or used on the communication assist device to request social contact. That would be such a helpful tool for a person with Angelman syndrome to use instead of, hucking an item across the room to get attention. Behavioral therapy also is a modality that can offer a whole lot. They can help with that process of the antecedent, the behavior, the consequence, the ABC system, to be able to understand what drives certain behaviors, because they can be confusing at times. They will oftentimes take data on the frequency of certain behaviors. They may try a new intervention, like, let's try ignoring this behavior, this sort of flopping to the ground behavior. Let's try ignoring it, and let's see if it decreases in frequency by counting it every week. And that's how we're going to judge whether an intervention is helpful or not. So they can really approach a challenging behavior. Okay, we're going to try and do this in response, and we're going to track to see whether it makes a difference. And that's going to help us learn what's going to be the thing that decreases this behavior. So it can be very helpful in tracking response. Sometimes when you institute a response to a certain challenging behavior, a person can up the ante particularly with attention-seeking behaviors. And sometimes things have to get a little worse for a week or two before they get better, with the hope that they will ultimately get better. So you watch for a little initial worsening before things get better. That doesn't necessarily mean that you're on the wrong track. And then to evaluate for medical contributors, to making sure that the doctors that are taking care of your loved one with Angelman syndrome are thinking broadly in this population who cannot oftentimes express what it feels like for them, and thinking broadly about these common triggers for pain that can go missed. And then the final thing I mentioned here is that a lot of these triggers for anxiety may be exposure to certain circumstances, like phobias around an animal or a doctor's appointment or separation. And it's possible that a therapist with experience working with people with developmental disability, or who's willing to be creative, could devise a little bit of exposure, gradual, little by little, to get people with Angelman syndrome more comfortable with that feared stimuli, whether it's going to the doctor's appointment, finding ways to do it little by little. Like first, maybe you just walk into the waiting room, then maybe you see the blood pressure cuff, then you move to putting on the blood pressure cuff, but you don't blow it up yet, and you sort of play with it, sort of gradually increasing the exposure to the thing that's feared, to make it fun, to make it a game, to make it less scared. Devising a situation where there's a little bit of separation for a minute or two, using a timer, and then a big reward if their behavior is good at the end of that timer, and gradually increasing the duration. These kind of gradual exposures I've seen be helpful for some people with Angelman. Now, before we talk about medications here, just why would you think about medicines? What are circumstances where you'd think about adding a medicine? So if you've tried a lot of these interventions and you've not seen improvement, like let's say you are able to advocate for ABA, behavioral therapy, That's applied behavioral analysis, ABA, for your loved one with Angelman syndrome, and it's not making any progress in a lot of these challenging behaviors. If there's a concern at home regarding the safety of the people in the home or siblings or safety of people at school, despite trying to put as many interventions as possible in place, if no amount of preparation can make a community trip safe, or if individuals are not eligible for day programs or in-home care staff due to the severity of safety concerns, you can end up in a situation that's highly limited, not being able to leave the house, being home all day. This sort of circumstances, that's a hard way to live, and we want to, change that dynamic. And if it's not safe to place any demands at all on an individual, obviously we all need to have some ability to handle some frustration in order to move forward in our lives, and for people with Angelman to make progress in their activities of daily living and their learning goals. So if we can't place any demands at all, that's not going to be oftentimes a recipe for success. So these are some circumstances I think about medicines. What medicines to be thinking about in terms of disruptive, agitated, aggressive behaviors, self-injury, property damage, or destruction. Buspirone is oftentimes a medicine I'll start with. This is an anti-anxiety medication, and it tends to be so well tolerated, not everybody, but most commonly, that it's a low-hanging fruit place to start because for most people, they'll tolerate it well. It has effects on serotonin. That's kind of similar to an antidepressant, and can be helpful in reducing behaviors that are concerning for anxiety in people with Angelman. In less severe cases, I might think about benzodiazepines, which sometimes get prescribed for seizures: Ativan, Klonopin, Valium. You might have heard of them, or your loved one may have tried them. Those medicines are acutely helpful for anxiety in the moment and can be helpful. Watching for sedation is the most common side effect. Moving from Buspirone to actual SSRIs, Prozac, Zoloft, heard of these medications, Celexa, medicines like that. These are actual anti-anxiety medications, antidepressants, and I've seen that also help with the frequency of some of these behaviors. There was a case series that was done by Hanslick's group in 2020 that showed some improvement with mirtazapine. That's also an antidepressant, but it helps with sleep. So it can be kind of two birds with one stone. And their study showed sleep indeed improved, as well as some disruptive behaviors. You have to watch for appetite increase with that medicine. And propranolol. Propranolol does the opposite of the fight or flight response. And these are a beta blocker medication. So it kind of blunts the effect of the stress hormones surging in the body. And that can be calming and help reduce some of these behaviors. In severe cases, it's worth thinking about seizure medications that can help the quickness of mood change. These should be particularly considered if you think that severe anger, high anger, quick moving to anger may be a trigger for a lot of these challenging behaviors. So it's, again, two birds with one stone if you find an effective seizure medication for these issues. I've written here topiramate, which is Topamax, can actually also reduce appetite. So that's one I try a lot. And then lamotrigine, clobazam, gabapentin, I've seen improvement with all those medications. Depakote I've seen substantial improvement with for these behaviors. But you have to watch out, that can worsen motor function for people with Angelman syndrome. So for people with Angelman syndrome, where their gross motor abilities and fine motor abilities are already a major concern, you might want to steer clear of that one. And then antipsychotic medication should be considered as a last resort. But I think 5 or 6 people with Angelman where risperidone in particular really helped them with a lot of these aggressive behaviors. So they can be considered. Quetiapine is an antipsychotic medication with a really low risk of movement side effects. So it's a place oftentimes I like to start. It is worth considering. But weight gain, movement side effects, these medications should be undertaken as a last resort because they can carry those kind of side effects, and increased appetite can be a real issue. All right, so revisiting John's case again, what did John do? Well, his family hired some in-home staff to help increase this planned separation. They were able to advocate for ABA resources, or maybe if it was an adult, they were able to get state organization to bring in some home caregiver, like a therapeutic mentor or a in-home caregiver or a PCA, and gradually increasing the amount of contact with that person. And it reduced some of John's expectation for constant interaction with his parents. They developed a procedure with the speech therapist for getting attention safely using a card that said, I want a high five or I want a fist bump, and also to have more safe affection rather than hugs, fist bumps, high fives, all sorts of other ways of showing affection that were not a physical close hug, which was overstimulating for John. They worked with the school BCBA around reducing some of these behaviors in school. They found that John really needed an individual aid to reduce some of this constant attention-seeking behavior that caused disruption in class. They introduced a visual schedule, so John had a sense of what was coming next, and a first this, then that program with a visual representation of what John was going to get as a reward when he did the thing that was a little frustrating for him. And John was able to get that concept, choose what it was that he wanted to work for, and that helped reduce some of the aggression and disruptive behavior with non-preferred demands. And then a Buspirone trial also helped John a little bit as well. So we'll move more quickly through our next two cases here. Sam's a 7-year-old with Angelman syndrome due to a UBE3A mutation. And Sam has always been constantly driven by a motor in terms of his physical. He is thankfully very able-bodied. Despite his Angelman syndrome, he's able to climb stairs independently. He has a lot of nice physical gains over the past few years, but the other side of the coin is he has boundless energy. He is constantly moving, exploring, taking things apart in his room, kind of a bull in a china shop whenever the family goes to a new location. And he is super easily distracted at school, giddy with any unstructured time, and silly, sitting on, rolling around on the ground, playing the dropping game with anyone who will play it with him. And all this is worse when there's less structure, and can't sit for any prolonged period of time for mealtime or online or education. The pandemic was a nightmare for Sam. So this issue, we might think about it as being hyperactivity, a constant need to move. And to a certain extent, there's something developmentally normal in younger kids, but as kids get older, it's expected that this constant need to move will improve over time. And for a lot of people with Angelman syndrome, a lot of them maintain with that super high energy past the age that you would expect. This is such a common feature of Angelman syndrome that some consensus guidelines that tried to develop like a clinical diagnostic criteria for Angelman syndrome, separate from genetic testing, put it as a really common feature. A hypermotoric behavior, almost 100% consistent. So a very common issue for people with Angelman syndrome, although it can be worse in some people than others. And hyperactivity seems to correlate very much so with how stressful it is, or the stress on the parent-child relationship for a child with Angelman syndrome. And a number of studies have attested to the issue of hyperactivity. There was a trial done by Clark and Marston, 72 individuals. This was a trial that was a community-based trial where they tried to get as many people with Angelman syndrome as possible, found prominent levels of hyperactivity that were elevated even as compared to other kids with developmental disabilities. And a separate study done by Barry's group that did 100 subjects that also found high rates of hyperactivity. So what can we think about in terms of non-medication based treatments that can be helpful for this? So first of all, easier said than done, but adequate sleep and exercise can make a big difference. A lot of families will talk about if we've built up 3 days in a row where there's been very poor sleep, I'm seeing really significant hyperactivity by that 3rd day. Not always the case. Some people, it doesn't seem to affect them, but not getting adequate sleep can play a role in increasing hyperactivity. And not having sufficient physical activity. For a lot of the adults I work with Angelman syndrome, they may be in a day program that it's not really enriched for physical activity. And that can be a real problem. Just sitting in one place for a long period of time, not great for a lot of people with Angelman syndrome. Educational interventions that can be helpful, taking frequent movement breaks. Like we said before, a lot of people with Angelman syndrome are really driven by the social interaction with their peers and the desire for social connection with their peers. And that's a major source of distraction. And so for some of the most important therapies, speech therapy, for instance, or what's being done in PT and OT, physical therapy and occupational therapy, those may be environments where it's better for the person with Angelman syndrome to be one-on-one. And then for the more open-ended things, music class, gym, things like that, those are the situations where being with the group and having that social contact with the group is a way to get that experience. But it needs to be more one-on-one for these important therapies. Using praise, using that social interests to be able to encourage on-task behavior. For people with hyperactivity who still are a fall risk, really teachers need to be aware of that. Caregivers in a day program need to be aware of that. There's a real fall risk here to watch for, that combination of hyperactivity but not being really good with gait. And again, OTs have a lot to offer here. For a lot of people with hyperactivity with Angelman, they may have a lot of sensory seeking behaviors, excessive chewing, ritualized movements. These are seeking sensation and they can be intense, constant throughout the day. So OTs can sometimes think about other ways those people with Angelman can get that sensory feedback that may be more safe for them. I had a patient who was ripping up her clothes and chewing them and swallowing the items, which wasn't safe, but introducing very firm chewy toys and changing them out regularly, because she could chew so often, she'd chew right through these chewy toys, was a really helpful OT intervention. Hand fidgets, chewy tubes, tubes that accordion out and back in again, all sorts of little sensory interventions can be a nice way for people with Angelman to get some of that strong sensory need and help them with sitting for a prolonged period of time, help with restlessness. Okay, how about medications? So guanfacine and clonidine are a common place that I'll start. These medicines similarly do the opposite of the fight or flight response. They have effects on the receptors that bind to adrenaline, essentially, and blunt some of the effects. Atomoxetine and viloxazine are medications that have effects on norepinephrine in the brain, downstream effects on dopamine, and essentially they help reduce hyperactivity. We still don't have a lot of research on how effective that is in Angelman syndrome and how well it helps. Oftentimes swallowing pills can be a challenge, so viloxazine allows, that doesn't need to be swallowed, atomoxetine does. So still some unknowns here, but that's a reasonable thing to consider. Stimulant medicines, Ritalin, Adderall, medications like that, in my experience, have been harder to tolerate, and so should be considered farther down the line because you can see behavioral side effects. And anecdotal experience has seen improvement with actual medications that are SSRIs, or serotonergic acting medicines. And then only in the most severe cases, oftentimes when there's associated aggression, medicines like risperidone, those antipsychotic medications, can really be helpful. So what they do for Sam, they instituted a picture schedule where his day was highly structured with activities, the sense of what was coming next without a lot of open-ended time. He had a activity schedule that was enriched for lots of outdoor activity. So Sam was constantly getting a chance to get that energy out and getting his sensory needs met. They increased one-on-one time for his important therapies, but outside of those important therapies, he got the social piece that Sam really needed with his peers, and that helped him make more progress in school. He had a little bit of improvement in his hyperactivity with guanfacine trial, and his parents sought additional occupational therapy outside of school to get creative around sensory ideas, and that turned out to be helpful for them. Okay, let's talk about our last case here for Liz, a 14-year-old girl with Angelman syndrome and due to a maternal deletion. And Liz had very good sleep for a long period of time with just a low dosage of melatonin. And then with the pandemic, things kind of got worse for her. She's now taking hours to fall asleep. The family can't separate from her at night without having a tantrum, and so they're needing to co-sleep with her when they hadn't needed to do that for years. And so sleep has become much more of a concern for everyone in the family. Sleep challenges, as you all may know, very common in Angelman syndrome, and appear to be the most prevalent in early childhood, but may persist into adulthood, and I've seen that many times. The types of sleep problems tend to be difficulty falling asleep, that's most common. Difficulty staying asleep, sort of mid-cycle awakening, where you're up for hours or maybe up for the day in the middle of the night, and reduced total sleep time as well. So these were the most common ways in which sleep problems kind of manifested. Why is it so severe in Angelman syndrome? There's probably a lot of different reasons. Some of the receptors in the brain that may play a role in sleep, GABA A receptors, can be affected by the deletion that causes Angelman syndrome, so maybe that plays a role. Co-occurring issues of constipation, incontinence, seizures at night can interrupt sleep. So there are co-occurring medical things that come with Angelman syndrome that can interrupt sleep. And then we've talked about how separation can be such a hard thing for people with Angelman syndrome. That can make the bedtime separation really tough. And hyperactivity can make it hard for people with Angelman syndrome to just do the sitting for 5 minutes that it takes for all of us to just fall asleep. If that's not easy for a person with Angelman syndrome, then it may be very hard for them to settle for bed. So an important thing to talk about is sleep onset associations. These are things that all of us may need to have in our environment, and we associate it with going to bed, and then we come to need it in order to fall asleep. That might be like a teddy bear, preferred lovey. It could be music, if you listen to music when we go to bed. If you're like me, it may stare at your cell phone before you go to bed, and kind of that becomes a sleep onset association. But for a lot of people with Angelman syndrome, it becomes a parent, a caregiver, a loved one, and needing for them to be there in order for falling asleep to occur. And that's a challenge because for a lot of people with Angelman, all of us, wake up normally at night for a couple minutes and fall back asleep. But if you have an association with needing a parent or caregiver there, then that little wake up can turn into a big issue of, where's my parent? Where are they? Am I close enough to them? I try not to make parents feel judged for co-sleeping, because sometimes you just got to do what you got to do. And sometimes that's what you need to do in order for people to get sleep. But I think I bring this topic up in this presentation to let you know that there are some behavioral treatments that can help with that. I'm going to name some things. Some of you may have tried some of these things already, but if you haven't, it's just useful to know about them. These are strategies to try and break that association with needing the parent at bedtime. One example of it is bedtime fading, pushing back the bedtime so an individual is more tired when they fall asleep. And the stronger the sleep drive, the easier it can be to have that separation, because someone is just so tired. And then when you've pushed the bedtime back far enough, then you've got a good ritual there with not needing the parent to be there, moving the bedtime back a little bit earlier to a reasonable hour again. Camping out, this is when the parent starts with co-sleeping and moves a little bit farther away, maybe using a cot or a sleeping bag or something like that, slowly moving themselves out of the room. Or the excuse me drill. This is a nice one where you start with co-sleeping and the parent caregiver says, "Ooh, I'll be right back. I gotta go check something," and is gone for 5 seconds, and then comes back and said, "Yeah, you did it, great job," and then gradually increases the time that they're gone little by little, until it's like, "I'll be back," and then they're gone for 20 minutes, sort of gradually trying to increase it. And then important things about sleep hygiene: consistency with bedtime, having a cool sleep environment, quiet, as dark as possible. And then for some people with Angelman syndrome, despite all of these interventions, they still just seem like they need less sleep than most people. And in those cases, a behavioral approach might include giving a preferred toy or a preferred item, or even, it's scandalous to suggest, but a screen like a tablet or a TV, to help an individual learn or sort of get trained to stay in one place so that the other people in the house can get good sleep. And that might involve using things like a veil bed, so an individual is enclosed in a safe environment while they sleep, a camera in the room to make sure that they're safe, ensuring the whole room is safe so that you can't wander around and hurt yourself. In some situations, I've seen this really help when people with Angelman just seem like they need less sleep. They may wake up at night, watch their tablet for an hour, fall back asleep, allow for the other people in the house to get rest. For some people, these interventions just don't work, but here's a trial where they did this intervention specifically of the excuse me drill. They sort of taught parents to do this excuse me drill with a behavioral therapist. And you see this visual here over on the right. The squares are how often you fall asleep within a short period of time. And the diamonds are disruptive behaviors around sleep. So you can see there's like a training period within the first couple weeks where they just look to see how parents are doing before they institute the intervention. You've got the dotted line, the intervention, and you can see for these 5 subjects, kids between the ages of 2 and 11, all of them had improvement in sleep onset association. All of them had reduction in disruptive sleep behaviors using this sort of excuse me drill with the support of a clinician. So that doesn't mean it's going to help for everyone, but it means that it's worth a try, that it can help. And then medications can play a role as well, particularly when there's a lot of agitation, disruptive behavior, screaming, like with that separation that complicates any behavioral plan from being helpful. So medications can be a very helpful addition. Melatonin's been actually studied in Angelman syndrome and found to be effective for some, not all, but some. Clonidine can also help with sleep initiation. That's one of the more common medicines that's been tried in people with Angelman syndrome. And looking at families that tried it, they reported good tolerability. Clonidine is good for sleep initiation. Trazodone is good for sleep maintenance, staying asleep, because it's a longer acting medicine. Also found in some observational trials to be well tolerated in Angelman. And then I told you about the mirtazapine case series. This again is an antidepressant. It can increase appetite, but can be very effective for sleep, worth considering. And then in most severe situations, quetiapine, I mentioned before, it's an antipsychotic medication. So it should be undertaken with caution because it can increase appetite so much, but it may help also with agitated behavior during the day. So what did Liz do? Liz's parents worked with a behavioral therapist, and they set a consistent bedtime. They got blackout curtains, so there was no light. They did a room of safety assessment. They put a camera in the room to make sure that it was a safe sleep environment. And then they worked with the behaviorist on this separation protocol at night, using the just one more second to try and break that association with sleep onset association with the parents needing to be there. They added some clonidine to sort of increase the sleep drive to make that separation go a little bit better. And they also changed up who the parent was doing the nighttime routine. So it wasn't just mom all the time, to, again, as another way to break that sleep onset association. They maintained a consistent wake time with some early daytime structure to avoid sort of the sleep schedule getting pushed back and back and back. And they looked into veil beds to see if that would be a helpful option for them. Can be expensive, but it can help with ensuring that someone is in a safe sleep environment if they do wake up in the middle of the night, not wandering the house and things like that. That can be dangerous. All right, so I am at the time where we should be finished here. So I'll just say in summary, addressing behavioral challenges starts oftentimes with understanding the function of behavior. Behavioral therapy and speech therapy play an important role in these treatments and really should be considered for all people that have got these challenging behaviors. And that medications can play an adjunctive role in the overall treatment plan and can make a difference as well, and may be considered, particularly when behavioral and speech therapy are not helping. So I'll finish up here, and I just want to thank you all for your attention, and hopefully we'll see you at conferences.
Thank you so much, Dr. Keary. Just want to thank you for your expertise today. My own daughter is 20 with deletion positive Angelman syndrome, and she really struggles with anxiety and aggression. And I think through your work, I've really gained a better understanding of her needs and how to support her, which I think can really improve her quality of life. You can visit the Angelman Syndrome Foundation website to learn more about Angelman clinics and how you could potentially even book your own consult with Dr. Keary, and that's at angelman.org. We hope you enjoyed this webinar today. Don't forget to visit Angelman Academy for more free webinars, and thank you for being with us today.